Hello there, Andrew Colsky here with Stop My OCD and Anxiety Enders for another podcast. Today we have Dr. Brandon Waggoner, who is someone who is both a clinician and a professor in the area dealing with OCD and related disorders. So welcome, Dr. Waggoner. Can you introduce yourself to the audience?
Yeah, thank you, Andrew. I appreciate the chance to come on and talk. So, like you said, I'm a counselor educator. I'm an assistant professor of counseling at Liberty University. I'm online, so lets me be in a different location maybe than school. So I'm actually in West Virginia, but I'm licensed in both Virginia and West Virginia, and so I do most of my telehealth. I do telehealth for my Virginia clients who practice there, but looking to do something more here in West Virginia as the opportunity unfolds. So, but yeah, I still maintain a client load, but my main role is counselor education and have several passions in both of those. But yeah, it's a little bit about me.
Great, great. Well, there's a lot to talk about here, but the first thing, just so that I get clear, so the students that you teach, are they just master students? Are they PhD students? Are they undergrad? Tell us about who you actually teach.
Yeah, so I teach in the clinical mental health counseling program. It's a master's program, licensure program, KCREP accredited. Um, so yeah, it's training. It's the course we all need as clinicians, or the program to get licensed, as we go into the field. So yeah, all master's level students, and we're actually one of the largest programs in the country. We have about 8,000 students in our program, so it affords me a lot of opportunity to interact with a good variety of students along the way.
Fantastic. And I this is a very a very special thing for me, because anyone who's seen my prior podcasts up until this particular episode knows that I pretty much always ask people, clinicians and others, did they ever learn anything about OCD in their master's program? And the answer is always no, never learned anything about it. And we've had a complete 100% streak of the same answer up until this podcast. And now you're the first person I've ever found who actually is a professor who knows OCD, because you practice it, but you also teach it. So this is a milestone podcast for us.
Yeah, I'm sorry to burst your streak. I don't know if we end the streak, because I can say for me, I was never taught this in my program. So maybe the streak continues. Maybe next time I'll bring in my students and they can break the streak for you, because I do teach them about it. But yeah.
Yeah, wow. So tell us, when did you first decide to get involved in the mental health field in the first place?
Yeah, so I'll try to make it a little brief, but I actually find this in most of my students, because I think counseling itself, you don't need a counseling bachelor's in order to go into the master's, and so we actually find a lot of our students, this is a second career for them, which was my case too. I actually have an aviation background. I was a pilot mechanic for a while, and yes, there's no correlation between the two, except you troubleshoot planes and you can troubleshoot people at the same time. But yeah, I was tracking with that. I actually taught at Liberty's aviation maintenance program, and it's really not a dramatic story. I was really working there. My wife worked there at the time, and so there was some benefits that were available to us to go back to school. And so I was like, well, let me go back for my master's, and I could have done business, seminary, or counseling. And counseling sounded the most interesting. And so that's why I pursued it. I didn't know where it would lead or what doors would open, but as I got into it, I was like, this is what I want to be doing. And so got into it, started practicing, got licensed, and then I was teaching aviation at the time. That's where kind of my love for teaching happened, just being able to duplicate yourself to exponentially be a part of helping the field grow, really accelerated. And so then I went back for my PhD in counselor education and supervision, and which qualifies me to teach on in our program. So
Mhm.
um, And so I still see clients occasionally too. I have about maybe 8 to 10 clients a week because my main role is teaching, but I still enjoy that. And I've had a majority of my clients be OCD just because, as you know, and we've talked about, there's just not a lot of clinicians that understand it or know how to, and we don't teach it in our programs either. So
Yeah. Wow. So you started off with your master's, and after you got your master's, did you start actually seeing patients in a clinical practice at that point?
mhm. Yeah, so like we all do, right? We have a residency afterwards in whatever state that we're in. Virginia was a pretty heavy loaded one at the time. I think we had 3,000 hours of residency. So um, yeah, I started with that and then got licensed and then could just continue on in a private practice. So
Mhm. So at what point did you come across your first OCD case?
yeah, part of me has to think about that too, because I probably encountered it way before I knew what it was. And you probably heard this story before too, right? That's
My story.
right. Yeah. I think it's how a lot of us get into it and I have residents and students now that as I talk about it, there's sometimes light bulb moments like, oh, I think this client has OCD and I didn't realize it. So um, there was there was one client in particular who he was actually diagnosed outside of me. He was transferred to me. He I credit him a lot with teaching me about OCD. And then there was a couple others where, as you know, if you just use straight CBT and thought replacement, it doesn't work. And so you try to do that, and I'm like, I'm hitting my head up against the wall. What? Why is this not working? Why can't we get you to this other thought? And that's when I really started to look at the research and dig into, oh, I shouldn't do CBT. I need to actually change my modality depending on the diagnosis, which I'm also very big on diagnosis as well when I teach and educate too. So yeah, it was actually a process that I mean I would say it hasn't even solidified yet. I'm still learning about OCD and its tenets, and I know you talk about some of the new treatments that are out there and things that are pretty neat that we can do. So it's a just like anything in counseling, we never arrive, but it's a growth process. But yeah, that started with some clients kind of educating me on it, and then me going into the research after I'm like, this isn't working. I need to learn. So
Right, right. So just like you and just like me, there's therapists who watch these podcasts, and I was going to say many, but probably all did not learn anything about OCD in school. And so, you come across, like, I remember, as I look back, I didn't know it at the time, but as I look back, I can point to probably 4 or 5 clients who clearly had OCD, and I just couldn't figure out what was going on because nobody ever taught me about OCD. Um, and so many therapists that I talk about have the same story. So once you realize that you needed to learn more about it for the benefit of those therapists who might be watching this particular episode, how did you go about learning about it?
yeah, so I get this question a lot, and especially from students because they're like, "What books can I read? What can I learn?" And look, I love books, right? I teach. We have to get books. But I always tell them, I said, go to the research, go to scholarly peer-reviewed articles. Um, they're they're peer-reviewed, right? So they're going to be what they need to be, and they're going to be the most up to date as well. Because if some of the books I would read, maybe I would have missed some ACT principles that were coming out because ACT is kind of a new kid on the block, and so I really tell everyone this is how I did it. I just started researching it. Google Scholar is my biggest friend. I don't know how we did research before Google Scholar existed. We had to go to a library and figure all that stuff out. But Google Scholar, it's right there on your fingertips. You just type in a modality, you type in OCD, and then you can start pulling up it doesn't take you long. Read a few articles, and it's like ERP is the gold standard, and you should be doing this, and you can't do this, and It's like, oh, okay, it doesn't take you long to look at, what's out there. And so, um, one other thing, I'll just throw this out there because I know you talk about, VR and some other things, but AI actually can be a useful tool. I know you had, I'm talking a little bit, but I was at your presentation at VCA, which was great. And you use some AI there, but you can actually type in, what do I treat OCD with? And AI will actually spit out a pretty good treatment plan
Mhm.
for you. Obviously, check with that and go to the research and make sure that it's correct. But sometimes it's like, I don't know where to start. AI can sometimes be a great tool to spit out some, oh, I need to look into that treatment a little bit better. So,
Yeah. No, it's, that's a great point, especially, right now, today, there's so much debate and discussion going on about AI just as a general topic. But, for me, I agree with you from the standpoint that if I sat and I did a Google search and I looked up all these different things and I gathered all this information, I still have to kind of put it all together in a meaningful way. And AI, when used appropriately, whatever you want to call appropriate, can do that for you. It's basically doing a Google search, gathering the information, and then putting it in a coherent paragraph or text, however long it may be. And I often use it a lot now to get me started. And then I'll read through. And then, of course, like you said, I'm going to check it because sometimes it's wrong. But at least it gives me a starting point and allows me to find resources and things that otherwise I might have been digging for.
right. It's like, it's an interactive Wikipedia. Don't ever cite Wikipedia. It's not a great scholarly resource, but it can be a resource to lead you to other good resources. And that's what I see AI doing. I actually I have tried to incorporate AI into some of my education. Don't use it to write papers, right? I'll say that for my students, um, but yeah, to help you as a clinician, it can be huge, right? To help you guide your where I need to go with some of these things. So,
Yeah. Yeah. No, it can be a big time saver.
mhm.
So you did this research and you started to learn about exposure therapy and you started to gather a lot of the evidence-based information. Did you have any practitioner that you were able to work with to kind of learn from, or did you just have to kind of figure it out as you went along?
Yeah, no, I was a lone wolf kind of, which is why I enjoyed connecting with you and doing this podcast, right? Because I think we need to collaborate. Because as you and I discussed, there's not many counselors who really know this and understand it. So those of us that do, like, I didn't have people I could collaborate with and be like, what do I do in these cases? So that's why I had to go to the research, go to some case studies, use some things. I would pull stuff from the IOC, the International OCD Foundation. Had some resources that helped guide me. Bought some books that helped me. But I'd say a lot of it was trial and error with my clients, um, because I'm like, well, I know this works. This is what the research says. Let me practice it. And I just kind of had to learn on the fly,
Mhm.
learn how OCD works. We tried this and it moved over here. And we asked, okay, let's work over here. Okay, OCD attached itself to the treatment. All right, let's stop compulsing about fighting OCD and those type of things. So it was real. That's why I say my clients taught me a lot. But I think that's kind of where we need to start because um, I know in the OCD literature, we talk about subsets. There's religiosity and cleanliness and taboo. I think those can be helpful, but I usually teach it like, look, it's just OCD. And to class some of my clients' thoughts to classify them, they're just so bizarre.
Mhm.
It's like, where does this fit? Well, it doesn't matter where it fits. It's still OCD. Let's still treat it like that.
Right.
Um, so that helped me as I got into that because I'm like, what do I do in this instance? Well, there's no book out there that's going to tell you because you'll have clients come in with an OCD thought that just makes no sense.
Mhm.
There's some that I have right now that I'm like, I can't wrap my head around why those thoughts are together. But I
Right.
don't need to. I just need to treat it like OCD.
Yeah.
But sometimes we get caught up into that of how do I do this with this thing? It's still OCD. Let's just treat it like that. Let's expose yourself. Let's prevent the response. Let's get out of the cycle that OCD gets you in. So whatever that method is, that's kind of where I left. But now I'm thankful I can have some people like you I can maybe contact and interact with, because yeah, I think we need to collaborate. I have many of my residents at my practice will come to me because I know I'm the OCD counselor. And so they'll come to me and ask me things. And at least I have experience to know how to direct them. But
Hmm.
there's some clients even now that I'm like, I'm not sure where we go with this. So
Yeah. Yeah. No, you're right. That is one of the unique things I think about OCD is that it presents in innumerable ways. There's no way to make a full list because you can always add more. But
yep.
the underlying functioning of OCD is the same. It doesn't matter what the thought is, it matters how we treat the OCD itself. So I'm sure that with some students, probably, because I get this a lot from other clinicians that I'm talking to. If you have someone who is not trained in exposure and response prevention therapy, you have often a conversation that will come up, which is, what do you mean I have to expose them to this thing that makes them distressed? Isn't that unethical? Aren't I harming them? I'm supposed to be calming them down, right? Tell us about that, whether you've had that experience and how do you deal with it?
Yeah. So I'll back up one step in my education too, because this is why um, in higher education we sometimes we gravitate towards helping our students know a particular theory. And I get that. I know why that's important, because you need to be grounded in something to know what you do. But I think sometimes we do a disservice when we teach theory over diagnosis. Because I think I call my theoretical orientation diagnostic in its approach, and that's because of OCD and what I've learned from it. Because I would say I would majority be an OC or a CBT counselor before OCD, and I learned it. Once I did, I'm like, look, I can't be a CBT counselor if I'm working with OCD.
Mm-hmm.
So I actually need to change my theoretical orientation based on what the research says works for this diagnosis. So I really try to teach my students, okay, yes, you can be grounded maybe in one, but how you work and how you view a disorder needs to come through the lens of that disorder. And that's really through OCD. I think OCD is one of the most unique ones out there, that it works so much differently than how we train counselors to do. And most of my students, most people who go into counseling, they do it because they want to help people. People are suffering. I want to help them. I want to see some sort of change happen. And so, yeah, it's a little bit of a shock when you start talking about OCD and be like, you know what, the goal of this is I'm going to make you more anxious,
Mm-hmm.
because that's when I know the exposure is working. If I'm ramping up the anxiety, because it's distressing, to live in that. And so it is very shocking. But that's where I go back to helping them know theoretically, what are we dealing with here?
Mm-hmm.
And how do I educate you as the counselor and the client on what this is and what this is doing. And every time I present or I talk about this, to students or to other people, I say, look, when I say this, it's going to go against everything, every fiber of your being as a counselor. Because it's like, I'm going to go do that. And sometimes when I say things had my clients do, it's very shocking, right? Like an OCD suicidal thought. Well, I have to expose you to that. Whereas we're trained to, suicidal thought, safety plan.
Right.
Well, if I don't know OCD, what did I do? I just gave you a compulsion to do
Yep.
when right? They're not actually in danger. They're afraid they're going to commit suicide. And so to be able to differentiate that, it's tough, but it's hard because it's like, I feel like I'm being unethical. Well, you're
Right.
not. it's diagnosis that's going to guide you. This person has OCD and you've diagnosed them with that. So that means all the treatment that you do that seems, this seems odd or this seems off, it's not, because it's actually empirically based, grounded. Research tells us this is what we need to do, even though you as the counselor may struggle with that. So that's where I kind of go. I think we teach theoretically and teach diagnostically, and say the diagnosis guides what I do with my client, not me. I'm not going to say, well, I'm CBT, that's all I'm going to use. I actually need the change. And our code of ethics actually mirrors that, right? That I don't impose myself on my clients. I actually work with what research tells me to.
So. Right. Well, see, that's a really interesting conversation, because as you think about what you're saying, and then you think about our prior conversation about AI, here's a big difference. AI is not able to do the level of thinking that you as a clinician do when you have to analyze all of the information the patient is sharing with you. And I can tell you many, many times where I have been working with a patient and I can pull out the DSM and I can check off a particular diagnosis. Yes, you got this. Yes, you got this. Yes. So therefore, technically, I could say I can diagnose you with X, but inside I know they don't have X. And you then have to go to that next level of analysis to try to figure it out. So, a great example is some people with OCD present in a certain way, but they actually have autism, or some people with autism present in a certain way, they actually have OCD. Or in many cases, they actually have both. And the only way to know the difference is to do your analytical thought to understand, why are they doing this particular behavior? Are they doing it as a compulsion, or are they doing it to soothe something else? And sometimes it can get really, really tricky. Like one of the big ones is sexual orientation OCD. It can get really down in the weeds of trying to analyze, well, is this someone who is, truly hiding their sexual orientation because of fears of things? Or is this someone who has sexual orientation OCD and they're not hiding anything? And how do you know the difference? And they can't figure it out because OCD is putting all that doubt in their head. So this is why it's so important. And whether it be OCD or whether it be any other thing, it's so important to have someone who's trained in the thing that you are seeking treatment for.
Yeah. But then, my thought goes to, where are they getting the training? Right? Because it's not happening in school, and it's kind of this nebulous. So yeah, I think we do need more of that, which is why I love talking about it. I love teaching about it. But yeah, I teach diagnosis is more of an art form than it is a science. There's a reason the DSM changes as it develops, right? OCD used to be classified under anxiety disorders. Now it's its own separate thing, which I'm glad we're moving in that direction, because anxiety is a huge part of OCD, but that's not the issue. And it's most commonly misdiagnosed, I think, for anxiety. It's what I mostly see. But again, diagnosis is, and there's always that blurb at the end of the DSM for a diagnosis is not better explained by another disorder. I see a lot of times people come in with, I call diagnostic cocktails. They've got this and this, and depression, anxiety, and PTSD, and a sleep disorder. A lot of those symptoms are going to be the same, or coming from the same place. If you have PTSD, you're going to have criteria met for all those other things. So just because you meet the criteria, I still have to look at, is something else better explaining this? And I think that's no better present than with OCD. But I just don't think it's in our mindset, because we know anxiety, we can know depression, we talk about trauma all the time. But is OCD at least introduced in our mind as counselors as, hey, maybe that could be a possibility? And that's all I want to do with my students. I'm like, here's what it is, here's how it works. Make it a part of your process as you think diagnostically, right?
Yeah.
And I have, I don't know, I shared in my presentation, I have a little grid that I work for criteria that can help us identify if something's OCD. It's unwanted. Is it fear-based? Does it have the or else principle to it? And the last one is, can you give it an answer? And so you talk about sexual orientation. I use that a lot with a client that has that, because sometimes I don't know.
Mhm.
It is like, I know OCD. I've learned a lot about it. I worked with many clients with it, but like you said, there's many times I'm like, I don't know. This is really tricky. So sometimes I'll just go into, let's just give it an answer. Let's just do some CBT.
Mhm.
I'm doing it diagnostically. And if it's OCD, it'll never work. It'll always be, yeah, but I just don't know.
Right.
So either way they're going, I can use some CBT, and that usually helps me determine, oh yeah, if we're just not going anywhere, it's probably OCD. If
Yeah.
it's just a sexual orientation issue or I'm not sure, CBT will probably help them in a way to do some thought replacement, go into some fears and that type of thing.
Mhm.
OCD will never let itself be satisfied with an answer. So
Yeah. That's a great way of thinking about it. I agree with you. That's really insightful. I appreciate that. Um, so you know, obviously you're doing the right thing in terms of teaching your students how to really think through these things. Um, have you run into any issues ever with like family members or loved ones of someone with OCD and them sort of taking an approach that might be less than helpful and having to work with them? Tell us about that.
oh yeah, it's the I think it comes up in almost all my consultations with my residents or students when they want to talk about it. They're like, yeah, but mom is really reinforcing this for them. I mean, it makes sense, right? We love our family, we love our loved ones, and so we see them in distress. What do we want to do? Right? We want to help them. So
Sure.
I think research backs this up. You'll see it in research several times where it talks about we need to be assessing for what it calls family accommodations. It's actually something we should be assessing as we progress with OCD. And I think it is, because I've actually had clients where I'm like, I know I'm doing the right thing, but we're not making the progress. And usually that happens. I have to step back and like, all right, what's prohibiting the exposure if we're doing that? Are we're not fully exposing ourselves? Is there some compulsion that I'm not catching? Or is there a family accommodation? And so
Mhm.
sometimes that's the case. So I mean, I had a client once who whenever she went home, her mom would do this entire ritual to her room, clean it, wash everything, make sure everything was in order, because that's what she told her mom she wanted, and it was distressing to her if it wasn't. I mean, what mom doesn't want her kid to want to come home? So I'm going to make it a comfortable environment for you to come home in. But what that was doing was just reinforcing the OCD, right? The compulsion. So I I don't know if I had the right answer to this. I probably am still playing with it. But I found that I don't really want to put the treatment responsibility on the family member.
Mhm.
It's not their responsibility to say, no, I'm not going to help you right now. I think there can be huge benefits for that if you can build it in and incorporate it. But I want the client to be able to do it for themselves. To be able to go to their family member and say, hey, here's what I'm doing and here's what I need you to do,
Mhm.
rather than me telling the family member that needs to happen. That doesn't always happen, but that's still something the client needs to deal with, because they can't have everyone in their life know OCD and know how to deal with their OCD. So they're just going to have to deal with people not accommodating or not accommodating or whatever, which is a big proponent of ACT. We talk about psychological flexibility, right? How do I be able to handle whatever situation happens? So
Yeah.
we definitely need to be aware of it and then help our clients troubleshoot it. You know, if it does mean talking to the family member, yeah, we could do that. But how do we help the client know how to deal with it and to take the steps on their own?
Yeah, no, I think that's very valuable because it is the client who has to figure out the ways to best help themselves and they have to draw appropriate boundaries at times, and they have to learn how to manage different types of folks and responses. You know, one area that comes up, I run a support group. We meet like 4 times a month, and I have people from all over the world that come. It's all online. And one of the issues that comes up is when you have, let's say, a child with OCD, you may have one or both parents who don't understand what OCD is, maybe don't even think there's anything going on with the child. And so their response is punishment. If my kid is doing this thing that I don't want them to do, then I should punish them and make them stop doing it. Except it doesn't seem to work. And we could go off into a whole podcast about punishment itself in general, but in OCD, you know, the fact that you've got someone who's doing something not because they're making a conscious decision to go do these things, but they've got OCD that's causing this to happen. And then they're getting punished for doing something that they're not in control of, really. And then that adds additional stress. And then when we add additional stress onto someone who's got OCD, the OCD gets worse. And that's been a real heartbreaking issue to hear people talk about during the support group, for example. And have you ever come across anything like that where you've got a client who is being punished for doing a compulsion, for example?
Not maybe as a child, but I mean, as you know, shame is huge with OCD. That's why there's decades before people find treatment for it, because how do I go tell someone I'm struggling with this? So you add punishment on top of that, that's just increasing shame. Why, right? And OCD loves to attack the things we value most. So my identity is a big value. So well, I must be a terrible person.
Yeah.
So it's just reinforcing that OCD thought, which is going to make me want to do stuff to try to fight against that, right? Which is where you get all the compulsions. So yeah, I mean, I probably have more clients punishing themselves than maybe, you know, because most of my clients are adults. So but I'll hear stories of that. I think it happens. I mean, I come from a very religious background. My faith is still very important to me. But religiosity, love is just a breeding ground for OCD in the way we talk about it and feed it. And so there's a lot of kind of punishment, shame aspects that can find its way into there.
Yeah. You know, that's when you talk about that part of it, the shame and all. I don't know if you've ever done this, but just because so many clients mentioned to me that they would spend time on the internet, and especially on apps like Reddit and similar apps, and they would read about other people talking about their own compulsions and OCD. And I went on because I had never been on there to look for that. So I set up a Reddit account and I went and I started reading it. And I don't know how to put it other than that is probably the most toxic place that I have ever experienced in the things that people were saying, and the amount of misinformation and guessing. And
social media is not the best place for us to self-diagnose, so or get treatment for. Yeah.
Oh my gosh. I mean, I literally now, when I start with a client, I tell them one of the first things you're doing, you're getting off of all the social media related to OCD. You may not read it anymore because it just drags them down. It drags them, you know, you do all this work and then they just get dragged right back into it.
Yeah.
It's
yeah, I found it's a lot of times you start to, because it's a search for certainty, right? And with OCD, like I got to know what am I okay? Well, the internet, social media is never going to, I mean, OCD is never going to be satisfied anyway, but social media is just going to be, well, am I worse than that guy? Or no one's mentioning this thought that they've had. So, and that's where OCD starts to attack its own treatment, right? Well, do I really have OCD then? Did I really explain everything correctly? And yeah, the more you can try to shut those out, the better. But that's easier said than done with some clients, right? So
Yeah, yeah. Well, it's funny because, here I am setting up these podcasts for the purpose of putting legitimate evidence-based information out there. And sometimes, I will get comments on a video, and the comment is, obviously somebody giving their opinion about something, but they state it as if it's a fact, and it's completely wrong. Or let me say it's not based on any evidence. And so, this is sort of social media in a way too, and I have to kind of balance that. And so what I do is I leave the post, I don't take it away, but I respond to it and I say, I appreciate your opinion. If you are stating factual evidence, I would appreciate if you could let us know the source of your information so that we can be aware of it. Or if it's your opinion, just let us know it's your opinion and we appreciate hearing your opinion. So I give them the opportunity and sort of the gentle reminder, if you've got evidence-based stuff, bring it out there. Tell us, we want to see it. We're not trying to hide it. But if you have an opinion based on nothing than what your friend told you, okay, thank you for your opinion. It's nice to know that people know that, but it's not helpful from a therapeutic standpoint.
right. Yeah. Self-diagnosis is not the best thing. There are people trained, and well, we're getting there to the people are trained in OCD, but trained in,
Right.
in other areas. So yeah.
So here's a question for you, and you may not have an answer to this one. In your opinion, and I'm asking for an opinion in this case, what do you think is coming down the road in terms of OCD treatment? Are there any things that you're aware of, that you're hearing about, especially as a professor? You're in the know. So what do you know about?
Yeah, I'm in the know, but I'm trying to advocate for OCD in a field that doesn't really. No, I mean, I have to go into some of my colleagues sometimes and be like, hey, maybe you can look at this over here. So um yeah, I mean, I think telehealth, I know you mentioned it too, that you actually like to treat OCD with telehealth, just because they can be in their environment, they can do stuff. So um, I think the more counselors who know how to do telehealth, because you still need to know how to do telehealth. There's a lot of other aspects to it than just jumping into it, which our code of ethics says, hey, you should know how to do this. It doesn't really tell us how to. So there's, let's go to seminars, let's know how to do telehealth, because I think it can be a huge avenue for it. I mean, the more we can give a real exposure to somebody, to their fear, they don't respond, they find out this isn't something I need to be afraid of. It's just a thought. The better that we can do that. So, I mean, I know you've talked about VR and the stuff that's going on with that. I'd love to look more into that. I mean, technology is, I think, a huge way we can, go into some of these treatments potentially a little bit better. And I think for OCD, it's going to help, because traditional, you come to my office and we sit and do talk therapy, probably isn't the best modality for OCD, if we're being honest. Like, I can do mental exposures, I could do maybe some basic things, but as far as you and your environment or creating an environment, um, technology, how we go about doing that. Um, you know, I I have grand ideas, right? If we think about doing a private practice of, being less traditional of talk therapy, there's a lot of people talking about walking, where we actually walk and go somewhere as we talk. I think there's a lot about mobility and some benefits to that. How do we incorporate that within our treatment of OCD, where we walk, go do something, go be active? Because it's a very active disorder. It's not just going to sit on one thought. It jumps around, it moves. And are we going to be nimble enough to know how to do that? So I think the more creative we can be in some of those things, the better. And I've seen a lot of creativity within counseling coming down the pike. I mean, there's a whole journal called Creativity in Counseling that pick that up and read it. Read what other counselors are doing, and there's great things we can bring over to the OCD side, right? Like walking, like equine therapy, like art. I mean, things like that can. There's lots of creative ways that we can do that. So, and then VR. I know you're more versed in that than I am, but it's a fascinating potential that I think is out there.
Yeah. No, I appreciate that. Because I have the conversation with people about telehealth a lot in sort of debating the pros and cons. And to me, there's two things about telehealth that really stand out as primary pros for it. Number one is, what you talked about is the client can actually be in the setting that is causing them the distress when we're doing exposure therapy. So, for example, the client who in their home, they're afraid to touch the handle on the toilet or the handle on the sink because of contamination. And they can take the computer, set it down in their bathroom and touch the handle on the sink. So that's one big benefit that they could not do in my office. And the second big benefit that I see is because there's such a small number of trained OCD practitioners out there, by doing telehealth, I have many clients that are hundreds of miles away from me or in different states, but if I'm licensed, that now they have access to an OCD counselor. Maybe they live in a small town or a remote area, and there's access to one or a handful of counselors in their small town, but none of those people are trained in OCD. So now what do? So it brings access to people that wouldn't otherwise have access to it. So I think those are two really big positives for telehealth personally.
Yeah. There's an aspect in the research called online disinhibition effect. And when we talk social media, you can see it. People will say things that they won't say in person. But I think that could be an advantage when we talk OCD, right? Because I'm going to experience something in my own environment that I'm not going to experience in a counseling office. And so I've found that the amount of exposures and the reality of that exposure is just heightened when they're in their own environment, like you said. So there's because I'm actually feeling it a little bit more, because it's not traditional. I want to alleviate you from that. I actually want you to increase the distress.
Right.
And I think telehealth can help us do that a little better. So
yeah. Well, I appreciate all of that and the conversation, and I have sort of two final questions for you. The first one is from the perspective of someone who is watching this video who thinks they may have OCD or believes they have OCD. What advice can you give to them about, okay, you've now seen this video, what do you do next?
Yeah. I've had clients who have done this, but I really would just say take away, if you're considering this as a disorder you have, go find a counselor who knows ERP or knows ACT. ACT can also be used for that. They may not say OCD, but if they say ERP, they're going to know OCD, right? And that may be telehealth. You may have to expound your availability, but I would say that's going to be the best option for you, because there may be some question, but you want somebody who knows it enough to knows how to differentiate it from other things. And I would say probably if you're suspecting that you do, it's more than likely that that's the case.
Okay.
That it is true. But go find a counselor who knows it. I had a client come to me, and she just moved into the area, and she called, I don't know, probably 10 counseling agencies, and nobody knew ERP, but she knew enough to know what ERP was and say, I need a counselor who knows this. And eventually she came to our practice. I knew it. And she got in and worked with me, and she's actually doing really, really well. But don't give up, but keep finding it and find counselors who know that, because that's going to be your best bet for someone to help you and to differentiate that with something else.
Yeah, and you make a good point there about asking the questions, because for whatever reason, and I think it's because people tend to want to be polite, they feel awkward about asking a potential counselor, do you have specific training in this? What type of training do you have? Because I have people who've called me, and they sort of, you can tell they're kind of hesitating, and I always say to them, ask me anything you want, because it's important to know. And the ones who advocate for themselves and check and make sure that the person they're hiring has the right expertise. I don't care if that's counseling or lawyers or accountants or whatever it may be. You want to make sure you're getting someone who can help you with the problem that you're coming to them for, rather than someone who is not experienced in it. So counselors expect patients to ask them about their expertise and their training and their the work. So don't be afraid to ask, because if you get someone who does not have experience in OCD and you have OCD, you can be wasting a lot of time and a lot of money, and maybe even getting worse because you're not getting the proper treatment.
Yeah. And you may give up on counseling in general, which it works. ERP is it just works, right? And so yeah, I tell my students, I mean, this is part of our ethics as counselors. We have to inform consent all of our clients of what our training is, what our expertise is, what our theoretical orientation is. So if your counselor doesn't, go ask them about it, because they should be giving you that information. And at least you know enough, hopefully by watching these videos and learning about it, that you know enough about the language to know what to ask, which is sometimes half the battle. I don't know what this is or what it is, but okay, here's some terminology I can look at.
Right. So let me ask the second question then, which is, so we talked about potential clients. What about for therapists who are watching this video, who do not have currently any training in how to deal with OCD, who maybe have that hesitation because of this concern about having to raise the client's stress and anxiety and distress levels? What is your advice to therapists?
Yeah, so I don't want to speak for you, but I know you are pretty passionate about this. But I would, hey, reach out to one of us, right? Reach out to people that are doing this. I know I love talking about OCD, um, just to bring awareness, just to talk about it, because there's so many people suffering with this, just life destroying disorder, that are not getting help. So the more we can talk about it and help other people, to learn and grow, it's just to reach out. And like I said, um, and this should be us for all, not just with OCD, but counselors in general. We should constantly be growing.
Mm-hmm.
Uh, I don't ever want to come to the point, and I know I kind of specialize in OCD, but I don't want to just specialize in one thing, because I think there's a myth of I'm comfortable because I know that, and I'm going to only work with that population. Well, that could probably cause us to stop growing. So how do we actually keep growing, keep learning? When I have a client where, man, this doesn't seem to be working, am I nimble enough to go look at what other treatments are out there? What does research say? How do I look at these symptoms differently? It may lead you to some different conclusions that can actually help the client and help you as a counselor grow. So I'm really, as you know, with OCD is a lot of shame. So I'm really big on not adding shame. So I would say for any counselor out there who maybe is like, oh no, I think there's clients that I've had that have this, I didn't know this. Hey, we both were in that same spot at one point, right? And so I sometimes look back on past clients and be like, did I ruin them? Did I mess up? And yeah, I wasn't as educated, but I am now.
Mm-hmm.
And I'm gonna move forward from where I am now, knowing that maybe that frustration, that opportunity is gonna let me help a future client in a better way. So don't get discouraged that I don't know, or I missed out, or I did something. Just use that as a motivation to keep going, because we're all not perfect. We're humans. We're not robot counselors. We're gonna miss things, and so, but am I gonna learn from the things that I miss? And so
Right.
that's important.
Great. Great advice. Thank you for that. So just to verify, you said, if I got you right, you are licensed to practice in Virginia and West Virginia?
Mhm. Yep.
So if somebody wanted to try and get in contact with you after seeing this video, how could they do that?
They can just email me, Brandon P. Waggoner at gmail.com. It's probably the best way to get a hold of me. And then we can consult, do whatever we need to. And if we need to go through my private practice, if we're going to set something up, or a referral, I've got some residents that I know I've trained in ERP that I know can do it well too. So, but yeah, that email, if they want to get a hold of me, they can. So
Perfect. Well, Dr. Waggoner, I always like using the title when you put in so much time to earn it, and you deserve it. So Dr. Waggoner, thank you so much for your thoughts and your time and sharing all this information with us. It helps to break the stigma. It helps to properly educate people about valid evidence-based information, which I think is so important these days. And I'm sure, there'll be opportunities to have you back on again in the future for some follow-up discussions on things.
I'll bring a student next time so I can prove that they're getting trained.
Right, you'll break my streak.
Yeah. No, I appreciate, Andrew, you and what you're doing. I love this podcast, what you're doing to get this out. And when we connected, I was like, I know I want to be a part of what you're doing too, and we can support each other. So thank you for your passion in this as well. It was exciting, and thanks for having me on. So
great. Thank you so much.
Yep.